And so after a few conversations and suggestions and $100,000 to do some work, we built a stroke gym. PT, OT, speech. Sat down and said, what would we need to create a rehab environment in the hospital? What else is more important than making sure that she has the support that she needs? And I'm talking about people who are going to sign up and show up. And then if you live in an environment that's not safe, then when do you ever rest? When are you ever out of fight or flight mode? And so we have to think about how do we make this environment for this person, even if that means someone comes to her home. That what people call concierge service should be baseline for moms.
You know, Catherine, I love catching you like at the beginning of just alive, just like, boom, let's go. Like, let's
Oh,
get into this content. I can't wait. I really
you know,
can't.
I can't wait to talk to you always. I hope you realize that. I think that you are a gift to the world. Um, whenever I join your lives and your conversations, I think she is expanding her reach by thousands just by investing time to talk to one. And that's the goal, right? With every patient, which I don't know what the better word is for that. I always say the person I'm loving on today. But with every person, every conversation, every school, every conference, you are reaching people and changing generational outcomes because you've decided that it's worth your time. And so I don't take any of the conversations for granted. And so when I get to be the person that talks to you, I'm excited. I'm so excited. So thank you. Thank you for having me.
That's how I feel about you. You came up when I was working at a DPT program as a potential, like, a keynote speaker for a white coat ceremony. And you had spoken at a white coat ceremony. And I said, how impactful would that be for students to hear it, learn your journey, but then also realize what you just said? You said every single conversation reaches and has the potential to reach so many people, so many patients, so many people that we love on and that we serve. And who in a better position to do that than professors, than program directors of our physical therapy programs that are kind of in this weird, like, transitional period. We're in a weird period, Catherine. Can we just talk about that? We're
Yes.
we're moving from this fee for service model, from this, I'm going to charge and bill and have my hospital dictate what patients I can see, in this robotic model of care. And you're showing us ways to reach people, whether they're in the hospital that you don't work for, but you're still having them advocate for their care. I want to talk about that.
Yeah.
Whether they're in the community, whether they're states away, you're working with my spouse and giving her guidance on her energy conservation that can prepare her for a successful fertility journey. Like, your reach is so broad. And I want to talk about that today. I want to talk about how PT students can learn from you about what they should have been getting from their programs about birth, about menstrual health, about women's health, about all of it.
I'm excited. I'm excited. I think as a student, that is the gift, right? That's the gift that we owe them as professionals. I think the beauty of the school is that they can decide who they bring in to speak. And so if they notice that there are gaps in their curriculum, or they notice that CAPTE is not requiring something, they can open their doors and bring people in. They can create experiences for students, even if it's outside of the normal. I felt like nine to forever, but whatever time they start and end now, right? They can do that. We've had students come to us and do their Christmas break so that they can get what they need, and because they knew they weren't getting it at school. And it was facilitated by their instructors. And so I think that there is such a beautiful marriage to be had between clinical providers, clinical PTs, and then also non traditional physical therapists, so the students can really see what's possible. Because at the end of the day, when I started my PT business, I realized from the onset that the way insurance reimbursed was not going to be what I the pattern that I followed. So, for example, when you look at maternal health, you notice that about 15 visits are reimbursed. And so that's about what moms get, right? And so if we start out saying, well, they have 15 visits, let me schedule these visits out to make sure that I get paid the max amount that I can get from insurance, then that means that if they need 16, I might not see them. And if they need 12, I might still bring them in for additional ones. It puts you in a position where you're making decisions based off of money instead of making decisions based off of what they need. And what I found from very early on in my career is that if you just serve, then all of your financial needs will be met. And you can change the environment where you work. And so I did have my own business, but I also worked at the hospital. And so if you see something that is not happening the way that you know it needs to happen for progress to be made, then you jump in and be the change, because otherwise you will burn out. And that's what I think about with students when they hear the statistic that people are burning out within their first year following physical therapy school. Can you imagine going through physical therapy school and then after a year being like, I don't know if this is for me? You're still almost $100,000 in debt, depending on what school you've attended.
Easily.
And at that point, you're just like, well, I might as well stick with it, and so I can pay off my student loans. But then you accept a salary that'll make it so that you take forever to pay off your student. Like, you're stuck. And so I knew early on I didn't want to feel stuck. And so every person that I saw for my business was seen for at least an hour and a half. And they were like, when I told them, hey, can you set aside 11 to 12:30? They're like, you're going to see me? You're going to be with me for an hour and a half? They love that. So when you tell them yes, and the cost is $200, and you'll also receive a program that has a video. So I'm going to be videoing so that you know what to do. You're not having to read through exercises, try to remember what was told to you. We're making you videos, and we're staying in touch between visits. And then they'll say, well, when's the next visit? When we decide that it is, right? So let's keep messaging and see when you feel like you need me again. It creates a lifelong friendship. And who wants to fire their friend? Nobody, especially if the friendship is mutually beneficial, right? And so that's the way it's been set up from the beginning. That's the way it has continued. And I love it because as a person who loves her family, all of my family, not just the ones that live in the house, I know that flexibility was one of those things that I would need to have. But I also knew that the way physical therapy is currently set up, it can be hard to get that unless you're willing to trade money for time, right? You know what I mean? Like, you have to be willing to put in the work so that you can build the flexibility later. And I just thought, no, let me just ask for the flexibility. You can ask for the raise. You can ask for the time away from work if you need it. You can ask for all of those things up front and then see what type of employer you have. As opposed to saying, they're offering this, let me just make it work. Everybody else is making it work. 98% of the people are making it work. So they're not going to be upset if 2% of the people say, well, I would love to work here, but can I do 30 hours instead of 40? Right? That's not a big ask. And can I work 10-hour days instead of 8? And it's a win-win because they need somebody who will see those people after 5 o'clock, right? Because they're still trying to discharge those people with surgery. So if I'm willing to stay until 7 or until 9, but I only have to work 3 days a week, why not? I mean, my boss was like, why not? Yes, you can do that. When COVID happened and everybody had to quit their jobs to work from home, I did not. I worked from I taught my son from 7 until noon. And then I worked from 1 to 9.
Because you were homeschooling, is that right?
Because I was homeschooling him. I had to teach him from home. And I thought, I still need to make money. So I talked to my boss. Let's change my hours. I work 1 to 9. He was like, you think people get out of the bed with you at 7 at night? I said, watch me work. Okay, watch me work. He was thrilled. He was thrilled.
And you were an acute care therapist at this point.
Mm-hmm. Yeah, and I loved it. I loved it so much. And, we talk about creating solutions. When I first got there, people with stroke and spinal cord injury were being seen the same amount of time as people who had, post-op heart surgery. They came in with shortness of breath. And so you're seeing them 10 to 15 minutes. We know very little can be done in 10 to 15 minutes with anybody. So I'll just start by saying that. But even less can be done in someone who has a neurological injury. And so after a few conversations and suggestions and $100,000 to do some work, we built a stroke gym. PT, OT, speech, sat down and said, what would we need to create a rehab environment in the hospital? Right? They're not here because they're still acute. They're here because rehab doesn't believe that they're ready to have an hour and a half's worth of therapy at one time. So we show them that they can have an hour and a half's worth of therapy at one time because we do it every day, and they get discharged faster.
And
And so
you were
it's
able
been,
to, so let me understand, you were able to create an inpatient rehab in an acute care environment.
I guess so. Yeah.
I mean, essentially, I'm trying to break this down for like the learner, right? And the learner right now are our first, second, and third year students, right? And all of this will go over their head if we don't like take pause to realize what you're talking about. Because for people to ask me in 2024, my hospital um, doesn't believe this is a profitable service. Physical therapy in the hospital after C-section in 2024, we have licensed professionals, doctors of physical therapy, compromising care that they can give to someone because their hospital can't see the profit. I need them to understand what your journey it is. You were an acute care therapist that with the stroke and neurological population, which is a difficult population, I can say that. I knew I wanted to go into school treating the neuro population because I had 3 years as a rehab tech treating an inpatient rehab. And then 3 months, all in threes, in 3 months before I started PT school, my mother had a massive stroke and I couldn't look at one person after a stroke after that. I could hardly get through the content in PT school, almost failed. And so when you say as an acute care therapist, you got with your speech therapist, your occupational therapist, your director of rehab, probably a whole bunch of other people, let's be honest, and you were able to fund a $100,000 rehab gym, essentially, that allowed you to treat people who were quote unquote ineligible for inpatient rehab, right? We need to build the foundation for how you were able to transform maternal health from acute care therapy, from a strong background as a neurotherapist, and then create essentially is what I call it, because I just got off a podcast where I called it that this morning and with Jerry Durham. This morning with the urogynecologist, I was dropping your name in Operation Mist, and I essentially was describing what you did. You created a hospital outside in the community. You created a community-based hospital. You created services that wrap around a person no matter where they are. We need to get to some foundation. So I'm speaking to the learners. So let's slow down a little bit. Is
Yes.
that right?
That is right. And yes, ma'am, we will do whatever you want. Okay. Yeah. No, you're right. And it's interesting because, of course, you get resistance. And that's what I think sometimes people can derail people. But I remember growing up, there was a sign. First of all, my mom used to always tell us, you can do anything you want to do. Don't let anybody tell you that you can't, that you can't. And we would read the serenity prayer every day, not together, it was just up in the house. So God grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. And I think that the part that always stuck out to me was courage to change the things I can. Because there were very few things in life that I looked at and said, I can't do anything about that. Right. And so one of the pieces of equipment we wanted was the Moveo. The Moveo is amazing. It's like a tilt table on steroids. You can attach TheraBand to it and do exercise. You can take it to the ICU. So for a person who can't tolerate upright sitting, it does that tilt table part, but then it also raises the head of the bed a little bit. You can get it to where they're almost standing. It was so awesome. I was like, we have to have it. So I know that it's a fifth of the budget. It's $20,000. This lady was like, you're never going to get them to approve that. I wrote the company and I was like, we really need this in our hospital. And I promise you, like, we'll be able to transform lives with it. They gave it to us for $8,000.
Come on. What?
$8,000. I was like, No is only no to people who are willing to accept no. And I understand that in our society, it is important to respect people's no's, but understand that somebody will be willing to say yes. And you can't let people who are around you make you think that just because they've been told no, that you are going to be told no. And so
Who
there
told you no? Who told you no?
another physical therapist who used to do the stroke stuff.
So
Who did,
you could have said, yeah, you're right.
yeah, yeah. She was like,
But
you're
you
never going to
wrote a letter to the
waste
company.
time. Yeah. Girl, listen. And the thing is, when I was in the hospital, because I want people to know this too, advocating for patients to me means that you do everything that you can to treat them as you would treat yourself or your family member. Because sometimes I'll hear people say, I gave this to X, but I wouldn't have given it to my mom. Like so you see them treat other people the way that they opposite of the way that they would treat their family members. And so for me, would I lose my job for a family member? Absolutely. If something is not right, I'm going to stand up for what is right. And I think the case that I think you'll under or students will get the best is that I had a patient and she had a hemorrhagic stroke, or he had a hemorrhagic stroke. And so in the hospital, they typically spend 15 days in the ICU. After the 15 days, they go out to the neuro floor and they're able to get their therapy started. They've been in the neuro ICU for 15 days without any movement. They're just laying flat on their back. So that was policy in our hospital. And so they get to the floor and I treat this person. And of course, day one, he's not tolerating upright sitting. He's not, we're working on things in the bed, trying to get him oriented slowly to sitting back upright. And so I'm in there for a long time. And we end up just sitting on the edge of the bed, maybe 15 or 20 seconds, and put him back. And so the whole time we're working on rolling, working on exercises, making sure that he's getting back acclimated to moving. And so I leave his room and the discharge planner meets me there and she's like, hurry to get your note in. We found him a place for discharge. And I was like, I'm sorry, he's not ready. He's not ready for discharge. Oh, and by the way, he needed dialysis. So this is on top of him not being able to move, sit up, whatever. And so she says, we wrote PT so that you would write a discharge order. He needs to go. And so I told her, I said, I will write up my note. And of course, within my note, I wrote up all the reasons why he was not ready to go, all the things that he was able to do, because for sure, we need to paint a good picture of his ability so that when it's time for him to leave, he can. But he wasn't ready to go. I said, give me 2 or 3 days and we can work, we can start talking about discharge. So she goes over my head, goes to the boss and was like, hey, your PT will not write that he needs to be discharged. So the boss calls me in the office. She's like, Katherine, this is like, I would tell you, this is maybe like 3 times a week. Because I'm not just going to sit by and let stuff happen that doesn't need to happen. So she was like, Katherine, is there any way he would be safe being discharged? I said, there is not. I am so sorry. I wish that he could go. He cannot go. He's not ready. So they had another PT go in the afternoon. She wrote the eval and discharge, said he was fine. He was safe. He made a lot of strides from the morning to the afternoon session. So the social worker calls me and says, her case manager, and she was like, we got somebody else to do it. Thanks anyway.
Wow.
So I was so happy she called me because the next call I made was to the facility that was accepting him. So I called the facility and I said, hey, I just learned that you have someone coming to your facility today by the name of such and such. She's like, they're like, yeah. And I said, do you happen to have a Moveo? It's like a machine where, and I explained it because of course they're like, no, we don't have that. I said, do you have a converter chair or tilt table, anything where you could transport the patient without them actually having to sit up? And they were like, no, we have to get them into the wheelchair. And I said, and then they sit up for dialysis? And they were like, yeah, we don't have any equipment like what you're talking about. I said, okay, so the guy that you're about to accept, he can only sit up for about 15 to 30 seconds. They were like, whoa. Yeah, no, we can't take him. I was like, I am so sorry. I said, but in a couple days, if you guys would just hold his spot, then he'll be able to come. And so they pulled the discharge. And so my boss called me back in the office and was like, you called the facility, didn't you? I was like, yeah, I called the facility. I'm not going to let somebody, when people are at
Katherine,
home.
you were fired on the spot.
Oh, I wasn't fired. I wasn't fired. No, girl, you
You
think
know
they're
how many therapists would
gonna fire
fear
me
for
for
their
being ethical?
jobs?
Go ahead. Go ahead. No, I'm not fearing my job. I'm doing the right thing. Toxins will build up in this man's system during the time that he's at that facility and cannot receive dialysis. This is what's happening to people at home who come into us with rhabdomyolysis and nobody found them, right? They're
Okay.
on the floor. And so I'm like, no, you can fire me if you want to, but
Mhm.
and I wouldn't even care. I wouldn't even follow it up with a lawsuit. That's what people think. Oh, I'll turn around and sue you now. No, nobody deserves to work at this. You'll be reported. You won't be sued,
Yeah.
but this will be reported because we don't want people dying because we're ready to discharge them. Right?
Yeah. Well, let me draw a parallel. This is important, right?
Yeah.
There is a woman, and we don't know what happened because we think one of our physical therapists saw her, but there was nothing documented in terms of her vital signs. There was nothing documented in terms of her just overall response to the activity. And she was 2 days at that point after C-section. And we had trained this therapist, but we were really kind of considering what actually happened in this appointment because within 12 hours, you're talking about hemorrhagic stroke. Within 12 hours, this woman was readmitted to the hospital with a brain bleed, requiring 2 burr hole surgeries so that they could drain the fluid of blood that was collecting around her brain. And this woman, when we went into her history, because she also had over a 9 length stay in the ICU, we found that she was a single mom. She had had 2 small children at home in addition to her newborn. And she had had a C-section that she had not been prepared for. It was an unexpected C-section, her first C-section. And so when I think about the therapists that are going to train our future DPT students who are going to be moving through patients, discharge. Oh, we just started a maternal rehab program. They're real easy. They're up and walking. All you
Mm.
have to do is do the assessment real quick and turn around. They're like 15 minutes. You could put your eval in, you're good. When I think about the environment we're sending DPT students into, I have to still like put in breaks in our conversation so that people realize you're not like the average therapist that would fear their job.
Mm.
You went and called the facility that your patient was being discharged to when in your discharge recommendations, you said this is not recommended. The
Right.
social worker, case manager, whatever, did it anyway, prepared the paperwork for discharge, and then you called that receiving facility to basically say this person is not appropriate because you don't have the equipment that they'll need to function. If we can't get that in the general population that we see, what are students to know about birth and maternal health, which Operation Mist is at the forefront of? What should our DPT students even know about birth so that you can establish behaviors in them, values in them, so that they can do this for any population?
Yeah. No, I love this. So, wow. Okay. I think we need to start by looking at the way we interview clients, patients, moms. We have to not only ask them the questions that are on the intake form, but really internalize it. So let's go back to your example, single mom, 3 kids, post C-section. If I were a PT and I saw her, there are so many questions I would ask her. How many people are going to be at home with you? I know that you are a single mom, but do you have friends, family, people who are coming over? If her answer is no, our session is spent making phone calls, right? We're not, what else is more important than making sure that she has the support that she needs? And I'm talking about people who are going to sign up and show up with food, who are willing to wash laundry. If you've washed laundry for you and Jenna, you understand it is never ending. And so can you imagine now 3 kids that need their laundry washed, that need to be bathed, that need to eat? And who is going to drive the kids back and forth? Because if you go to the grocery store, you have to take the kids with you, get them into and out of the car seat. How much energy is being expended? So yes, that first session, if we're doing nothing else, we're making phone calls. We have to stop thinking, okay, we check the box of walking, of getting into and out of the bed, of I mean, that's really what people do. And then maybe sending them home with some exercises. But no, we need to figure out, how can we create the environment for this person to thrive? There is a concept called cerebral autoregulation. And we all know it. In the brain, the spinal cord, they are protected. Like there is no pressure change that's tolerated very well in that system. And so blood pressure increasing in the brain is not a concept that throughout life we have to really worry about because it's protected. But during the first 2 weeks following delivery, the brain is not able to regulate blood pressure in the way that it is outside of this time frame. And so if for any period, and I know we have the deaths taking place up to 6 weeks postpartum, but in those first 2 weeks, we need to make sure that someone is in the home with a single mom. Because if her blood pressure goes up like it's supposed to, right? When we get up and we move around, blood pressure goes up. We exercise, it goes up. We take a shower. The only time it's not really up is when we're laying down. And no mom is laying down for 2 weeks straight. And so we have to start thinking, how do we make sure that what is going to happen physiologically is going to be protected by the environment that we create? And so that would be one thing, setting those things up. Also, education about how to take blood pressure. People who are like, send me the position. How do I take blood pressure? Do I just take it when I first wake up? No, actually, I want you to take an entire day and take it throughout the day. Yes, when you first wake up, after you brush your teeth, while you're sitting on the toilet, when you're after you take a shower. I want you to do it after you eat a meal. I know the recommendation is we'll wait about 30 minutes so that you get an accurate reading, but the reality is it's accurate because it belongs to me. I just need to know what's my range, right? Take it after I exercise, after,
Wow.
before I go to bed, after I go run errands, after I have a challenging conversation with my spouse, with my boss, after a long day at work, and then after a day at the spa. We need to know our numbers. And as PTs, we can teach people what numbers matter and what the numbers mean. Because it's very important. People, if you tell them take your blood pressure every day, but you don't tell them why, you don't tell them that the number one reason for women dying in the US is heart disease. It's heart disease. So yeah, so you need to know your blood pressure, right? And so some other numbers though, because I'll get back to the examples, some other numbers that they should know, whether they are helping the person find the number, like resting heart rate, blood pressure, or just recommending it. And that's a big part. It's like we don't have to do everything. We just have to tell them what to look for. And then we have to know what the number means in case they come back to us, right? Because sometimes they take labs, the labs are taken out or whatever, and then they never get a phone call back. And so they just assume it's all normal. And so some of the things I think people should have, just in general, but definitely for maternal health, is GFR and creatinine. So how are your kidneys functioning before you go into pregnancy? Because we know that the kidneys are going to work at least 50% harder starting at the middle of pregnancy. And then it continues to work harder through the second week post-delivery. So are you here? So when you put the kidneys with the body's inability, the kidneys working harder with the body's decreased ability to manage blood pressure, then it all makes sense, right? Kidneys have a lot to do in terms of filtering all the fluid, all the things that the body no longer needs after delivery. And so we always, I think, we think about the kidneys as something that produces urine to get rid of toxins, but we don't always talk about how it releases the hormone that will ultimately end up making hemoglobin. And we need hemoglobin. We need oxygen in our bodies, right? And so for the students, as a review, erythropoietin, right? That's what the kidneys are putting out. And then the kidneys also regulate blood pressure. And so if they're working harder and they're supposed to be still regulating the blood pressure, then we need to change something externally so that our inside can do the work that needs to be done. So want those kidney numbers. We talked about blood pressure, resting heart rate. I know everybody can't get an echo, but that would be nice. But a BNP and numbers that'll let you know how is the heart functioning especially if someone has a history of heart disease in their family. They deserve that. The kidneys are going to work. I mean, I'm sorry, the heart is going to work 50% harder as well. And as PTs, we would never meet someone, know that they've been on bed rest, let's say for even 2 weeks, 3 weeks, and then say, well, tomorrow I want you to run a marathon. We would never do that, right?
Right.
And we know that physiologically it's not safe to do that. And yet we have women who go throughout their pregnancy, and let's say they run into bed rest at 7 weeks, I mean, 7 months. So at 7 months to 10 or 11 months. So let's talk about that too. We are, we have to normalize that pregnancy does not end. It's not a 9 month process. So let's just go ahead and start saying up to 44 weeks. So someone could be pregnant up to 44 weeks. And that way we're not having any unnecessary inductions, unnecessary C-sections. We just understand that there is a process that has to take place. And somewhere along the process, the body will naturally go into labor and allow a woman to deliver. And should something happen to stop that process, then sure, let's go ahead and intervene. But we shouldn't think that just because women are being invited to deliver their baby at 39 weeks, that that should be standard practice. And there is a reason for that as well. But the heart is going to work harder. And so if she's on bed rest from month 7 to month 10, and then she goes to deliver her baby, what we have to understand is that her heart rate reserve, like she's using 70 to 90% of her heart rate reserve based on research. Okay. And so we got to use the research to inform our decisions. So if their heart rates are getting up into the 150s to 190s and they've never exercised, they really haven't moved around as PTs, you know how much opportunity we have to prepare them? It is as exciting to me to prepare someone for the marathon of delivery as it is someone who is preparing a professional athlete to run in the Olympics, right? Because we're bringing forth life and we need to be prepared for that. And I think that as PTs, we have to stop thinking, oh, they came to us with low back pain because of their pregnancy. They came to us because their feet or their hands were swollen. So I'm going to take care of that carpal tunnel, right? Like we need to really start looking at the person and saying, what did they not come to me for? Right? Can we just start with that? What did they not come to me for? What did they not tell me? And so I think so back to our nice lady. So she has the 3 children. So the other thing that I would like students to think about is what other resources might she need? So if she doesn't have transportation to her 6-week follow-up visit, then can we set up some childcare? Not us, but we look in the environment. We are, as PTs, as people who want to work with people who are going to give birth, then it's our responsibility to make relationships, right? Because out in the real world, we're not going to have anybody saying refer here, refer there. We have to build our referral network. And so just like we would do it for PTs to PT, we have to look for places that provide transportation so moms can get to and from their prenatal appointments and postpartum visits, and not just to their OB. They might be going to see somebody else. If they're lucky, a dietitian. They might have doulas coming into their house. So we want to talk to them about, hey, if we can't have family come over, is there a way that we can get some community sponsored doulas? There are hospitals now that are sponsoring doula care in rural communities. So we need to find those resources. We want to make sure that she has access to healthy food. Can she get food delivered instead of having to go out and get it? And make sure that she's in a safe environment. So if she is in I think about stress. So over the course of pregnancy, stress is going to increase in terms of whether we're sitting in fight or flight or rest or digest. And not only does stress increase over the course of pregnancy, but it's also harder to kind of shift between the two, to go from being in fight or flight to back to rest and digest. And so if we can minimize her stress, according to research, then she has a less of a chance to go into labor prematurely. Same thing with sleep quality. So the research is out there saying, hey, this is what needs to be done. So I'm just like, why not just do it? And so we think about stress though, it's not just the stress of exercise or of eating poorly or working, your job responsibilities, but it's also the stress of being a mom, taking care of those other 2 children. And then if you live in an environment that's not safe, then when do you ever rest? When are you ever out of fight or flight mode? And so we have to think about how do we make this environment for this person, even if that means someone comes to her home. And so I feel like as providers, instead of always thinking, okay, let's schedule the person to come into us, we can go to them. And that what people call concierge service should be baseline for moms. During
Okay.
those first few weeks, they are going to be home and they are going to be doing a lot. And so for them to pack up all of those children and go anywhere, it's a task. And it's a task that's going to task all of the organs inside of their bodies. And so if we can make a better, safer way for them to do that, I feel like that's our job. I mean, then we do need to do the regular things. Like we know that if, let's say, someone has a vaginal delivery, because we talk a lot about cesarean.
Before you go there,
Yeah.
because I do want to kind of cue up the mom after vaginal delivery that returned to the hospital 3 days after spontaneous vaginal delivery. She said herself, medical team said you had no complications. Little spike in blood pressure, you were fine. She returned to the hospital within 3 days with acute heart failure and postpartum preeclampsia. This was a mom who was white middle class, who had her husband at home, who had her mother at home, and who had her husband's mother at home. She had 3 kids herself, okay, different lady, 3 kids, including the newborn. And she basically had an adult for every child: the newborn, husband, mother in law, a smaller child, 3 years old, other child, 6 years old, her mom. She could rest and still was readmitted to the hospital within 3 days of her birth. So when you're talking about cerebral autoregulation, I remember this as a PT student, but in all those labs you just mentioned, Katherine, I've never been taught this in the context of pregnancy and postpartum. I have never had education while I was in PT school or in my residency at Duke University Women's Health Physical Therapy program in the context of what you just laid down. The
Mm.
labs and the cerebral autoregulation that is dysregulated in the first 2 weeks after birth. We've never been taught that in the context of pregnancy and postpartum. And so, what in terms of that, because you were moving into vaginal delivery and I said, speed bump, hold on. What in the context with that woman's situation, and I could probably get into her readmission, it was awful.
Oh my God.
She was put on a blood pressure lowering medication, magnesium sulfate. The nurse got her up out of bed and she completely collapsed in the bathroom because a blood pressure lowering medication does what? Syncope.
Yeah.
Orthostatic hypotension. She was out for 5 minutes and she remembers reading her medical records. Syncopal event for 5 minutes. So that was a whole thing there. Still no bedside commode, still no evaluation from a PT or OT to assess how taxing was going up and downstairs on her system that's still trying to regulate itself,
Yeah.
right?
Yes.
What would you want PT students to know? First of all, in PT school, do not put all your eggs in one basket. Get that education outside of your program. Like
Yes.
you should already have inventory of populations you want to affect because the gaps are so big. If most of you are going to try to treat athletes right now after ACL repair and get them back in the game, the most motivated athletes we have are moms.
Yeah.
There's no one more motivated. They have to go to work right when they're going home. Many of them do. They're the one of the most motivated clients that you could have. So if you could talk to what you already teach students about birth, what are you teaching them, especially about the most common birth delivery type, which is vaginal delivery? What are you teaching students?
Yeah. So you mentioned something though, and I wanted to go back. In terms of vital signs, regardless of setting, we take them. I don't understand when I see someone say, we just don't have time, right? And there should not have to be a campaign called Vitals are Vital because everybody, right? We should all know that. And so when I was a student, I got talked to about taking vital signs, and it was not nice. They thought that it was not necessary. And I went into a woman's home. When I see women, it's normally 2 or 3 days after they leave the hospital. So I go into their home and treat them and teach them all the things that I watch them do what they do, and then help them do it better. And with energy conservation, get them equipment that they need, let them know that it's okay to not be able to do everything back to back like you did before you delivered. So I think going into their environment, whether it's there or they're boxing or they're doing Pure Bar, or I mean, get your memberships. Okay. I'm always like, listen, get 5 guest passes. When you sign up, ask them for guest passes so I can come and watch you and see what you're getting back into. Because you can tell me, oh, I feel great when I'm at the gym. I know I need to see what you're doing so then I can help prevent issues from happening down the line. Bringing them into an outpatient clinic that is an artificial environment without any of their children. When we talk about carryover, that's like having someone swim who's trying to get ready for a marathon. Yeah, there are benefits to swimming from a cardiovascular standpoint, right? But the environment is completely different. And so we cannot pretend like we can recreate an environment. Let's just go into the environment. So if you have the bandwidth, I would just say, go where the mom is. They will pay you to come with them. And that way you can really give them individualized care. The first time I thought about this, it was when someone came to me and said, I was told I can't do crunches, I can't do planks, I'm talking about a bunch of stuff. And this was when I was doing more pelvic health, traditional pelvic health stuff. And I said, where did you hear that? Where did you read that? Why would someone tell you that? Like, I had not a clue. And then I realized everybody was saying that. And
Katherine,
so
everyone. Pelvic health therapists, yes.
Everybody. And so I was like, show me your plank, right? And so if I get up underneath her and I tap and her linea alba is not like, right, like she didn't have the diastasis in that position, then what are we worried about? Can we teach her how to do it without holding her breath? Can we teach her, like, why are we stopping someone from doing a whole host of exercises that they love? Okay. Now, if I go under there and the gap is this wide, then yeah, let's modify. Okay. So the floor didn't work. Why don't we do it on the tabletop? Why don't we do it against the door? Why don't we get back to where you can do it on the floor and then explain to them why we're making that modification? Those blanket statements, that's the problem. The problem with the whole maternal health crisis, with the healthcare system in general, is that we are comparing people to standards and then treating them based on protocol. And can you blame people for doing that?
What do you mean by that? What do you mean by that?
So let's start with blood pressure. So if someone says, what's your blood pressure? Oh, I don't know it, but I know it's normal. Okay, so what's normal? Well, as long as it's not over 130 over 90. Let's say that a person who doesn't know the numbers would say that. I said, okay. So, but you don't know your blood pressure now. And so they are comparing themselves to some standard that they heard. And so you would think, wow, that's preposterous that they would do that. And yet in healthcare, when you look at the way maternal health is done, you do not have a problem until your blood pressure is 140 over 90. You will not have a huge intervention take place until you're at 160 over 110. And so those are standards that are used to inform care, but they should not determine care. You have to look at the person and say, her baseline blood pressure was 90 over 60. This happened with one of our moms, the only mom who got preeclampsia with Operation Miss. She was on for 2 weeks. She got on at week 28. By week 30, we caught her preeclampsia. Why? Because her blood pressure increased from 90 over 60 to 120 over 80, and we were concerned. She called her OB with those same numbers, and they said, stay home till Friday, you're fine, put your feet up.
Come on now.
So now,
wait, I'm sorry. No. Did they know her baseline was 90 over 60 and
yes,
it got up to 120 over 80, and they were still considering 120 over 80 is not concern.
It's good for pregnancy. This is what they do. That's good for pregnancy. I'm telling you. And the other thing is that we're not asking the right questions. So I asked her, okay, so they said to put your feet up. Are you taking off of work? Well, no, I still have to work. So driving an hour to get to work, working 10 hours, driving back an hour, that's not resting, right? That's not resting. And so in addition to that, though, I said, well, how have you been feeling? Are you having any swelling, having any pain? And so some of the symptom signs that preeclampsia could be coming on would be a headache, dizziness, pain in the left upper quadrant of the chest. And So I'm asking about these things, and she says, "Well, yeah, I've been swelling a lot. Like I've been going to and from the bathroom almost every 5 minutes. I called into work today because when I stood up, went to go pee, I came back, sat down, had to pee again, had to pee. Like I had to keep going, and my legs feel like elephants, like they're heavy. I feel like I'm having to drag. Those are red flags." I said, "Ma'am, I'm gonna need you to go to the hospital right now. The worst thing that could happen is that they tell you to go back home, right? That everything's fine, checked out, you go back home. We both have a peace of mind. I doubt that that's what's going to happen, but let's just go." She went. Turned out that she was in the early stages of preeclampsia, and they told her, "You will be delivered." Now, this is the sad part. She goes there to get care. They admitted her with the diagnosis of preeclampsia, put her on the magnesium drip, whatever, got her blood pressure under control, sent her home with no meds, and told her that she would be back in a couple of weeks with preeclampsia with severe features. They were sure. And that's all they told her. You could die, your baby could die. And so as a PT, we think this is not PT, right? This is not PT. Like helping her navigate this is PT, right? It's not traditional PT. It is what a PT would do who sees that this person is about to walk into a disaster, right? So you call me and they say, "Oh, you're about to go into a severe state of preeclampsia." My first thing is, I know you said you couldn't quit your job, but you're going to have to take your maternity leave today. So you go ahead and call in. Husband's going to have to get another job if that's what needs to happen. And he was so on board. When I tell you, he was like, "We're going to make it work. Whatever we have to do, we're going to make it work." She went on to carry that baby for an additional 6.5 weeks, delivered. Baby was perfectly fine, but she also changed her diet. And so you talk about different courses. If you're listening to this, don't just take PT courses that deal with maternal health. You want to take OB, doula, dietary courses, like things that can kind of supplement your knowledge just enough that you know who you can refer to get the patient the help that they need. Because we can't be everything to the patient, but we can refer them to people who know how to do what needs to be done in the moment. And so she completely overhauled her diet. Husband threw all the food away that they had, went to the Whole Food store, got more food, realized that based on the watch, clutter stresses her. And so he decided to get her a hotel room for a week so that she could be in a space where she could clear her head, do a reset, slept for 7 to 9 hours every single night, no matter what, drank water. Like she was never a water drinker, but she became one. I mean, it's about the relationships that we build with people, right?
Right.
So I think that instead of focusing on what does this intake form say, we ask them the questions that are going to really give us the best opportunity to help create an environment where they're going to thrive, regardless of their diagnosis. And then we have to make sure that they know how to monitor those things as well. And so the lady that you talked about who got readmitted, what if she hadn't been taking her blood pressure? What if she was so busy that she ignored her symptoms? She would have not even had the opportunity to go back to the hospital. And so some people don't know how to take their vitals. They don't have a pulse oximeter, right, to check their oxygen levels and their heart rate. They don't have a thermometer to check their temperature to see, okay, am I getting an infection? These are things that we can recommend to our patients. We recommend walkers and canes and crutches. We need to recommend the things where they can monitor their own vitals instead of depending on us taking them every time they come in to see us. It's not enough.
So, question for you, because she did have signs and symptoms of anterior, she called it throat pain, right? Like she was showing cardinal signs of there is something wrong with her heart. And I've heard from quite a few like PT students, cardiopulmonary physical therapy isn't like necessarily covering the number one killer of women during birth.
Right.
Even though when I think of a course where DPT students could be prepared to treat this population the way that we need, right? In our communities, because Black women are just dying at astronomical rates compared to their white counterparts. There's cardiopulmonary physical therapy that's going over labs like BNP, that's going over lifestyle medicine and talking about nutrition and talking about the coaching and the consulting that's done around a person's life and the stress that they have. Because we know when treating someone with heart disease, There's a lot of different factors more than just working with them on gait training. Like, we're going deep with that population. What would you say to even the professors that are teaching in cardiopulmonary physical therapy today? Why are they leaving this patient population out? I don't get it, Katherine. I started treating the maternal health population, and all I can see was cardiovascular health everywhere I turned.
Everywhere, everywhere, everywhere. If we only address that, only that, the person would be better off. I stand flat-footed and firm and say that. Musculosis, so which, but when you look at the boards, you have to really think about it. Unless someone, if the boards are 40% neuro, 40% ortho, 10% of 20% other, right? Which includes cardiopulm, wound care. I mean, nobody's focused on that because they want their students to pass the boards, right? So every bit of additional content seems like is taking up more time, but in reality, we have to teach to the populations that we will serve, and a lot of women will go on to have children.
We have
Just
3
by
million in this country, 3 million giving birth every year. That's
and so
that's quadruple the amount of knee replacements. So, I mean, I get what you're saying. We're teaching to the boards, but my program would actually say we're not teaching to the boards. So I'm kind of like,
mhm,
there's an internal conflict. Like, we were actually taught by professors who were like, we're not teaching to the boards, we're teaching to patient care. We're
mm,
teaching to practice. We're teaching to evidence-based practice. And evidence-based practice would be you're preparing your students to treat people after the most common surgery performed in the country, which is cesarean section.
absolutely, absolutely, and it's not happening because students are coming out saying they're scared. They're scared to treat. I'm not. It's not just women who are 6 weeks postpartum. They're afraid to treat postpartum 2 years. They don't think that they have the knowledge. And the thing of it is, if the schools would give it to them, then they would be just as comfortable treating someone post vaginal or cesarean delivery as they are treating someone post total knee replacement. So the work just has to be done. That's what I would tell them. It is so easy to incorporate this material. It doesn't take long to teach it, and it's going to save lives. Like, that has to matter to you. And luckily, I am a part of a couple of different universities that really do take that seriously. They bring me in 1 or 2 times in their class, and we teach all of this.
Wait,
Not
during a semester,
during the semester.
1
It's
to
just
2
their
times.
way.
What are you talking about? What are you teaching
So
students?
I'm teaching them the major causes of maternal death. And so, so why women are bleeding so much, the problem with Pitocin, the medicine that's being used to induce labor, because it's not just that women who experience it say, I had a terrible birth. I was in so much pain. It's that their heart is being affected, right? Like, what are the cardio implications of someone being put on Pitocin? And to know the research and stay on top of it. The research already says once you go past a certain number, it's unsafe. It's unsafe. And yet the Pitocin keeps getting turned up. And so teach them how to advocate, because it is about them treating their patients, but it's more about them protecting themselves, right? PT, how many women do you see in PT who have sisters, aunts, cousins, moms, like daughters? So I teach them what they need to know so that they can properly advocate for their patients. But so we go through it just like it's not like it's an OB course, but it's like a OB course. It's not so much traditional PT, but how can we as PTs, when they get to us pre-pregnancy, how do we prepare them? During pregnancy, what are we doing? Post-delivery, what are we doing? And so that's what we do. We break it down and we say, okay, well, during the pre-pregnancy visit, they're probably going to come in around third trimester. So at that point, we can start teaching massaging the vaginal opening, right? So we teach them to do that. We teach them to breathe the baby down instead of pushing the baby out, because we're not really pushing the baby out anyway. If we think about the uterus and it being a smooth muscle, are we controlling it? No. And we would all agree that the uterus is what delivers the baby. And so if we just breathe, it'll be okay. But the reason that this is important, and this is what I teach students, is that if 90% of women tear, they shouldn't be tearing, but 90% tear vaginally, then wouldn't somebody say, wow, something must be wrong with this process, right? Because there is not a single woman that I have personally worked with that has torn vaginally. Not a single one in all the time that I have been working with women. And so, but 90% of the time they do. And so if we teach them, the reason I teach about the breathing is because there are a couple of problems with pushing a baby out, and the tearing, if it gets bad enough, can result in the person bleeding too much. If it's a sulcal tear, it's inside the vagina, it can take a long time to heal. And so if a woman is bleeding, 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 that's one of the causes of death. And so we need to know how to prevent someone from getting there. We also talk about labor positions. And so it's not just about what hurts, what relieves pain, how to breathe through no, it's about if someone is laying on their back and the sacrum, the hip unit, the pelvic unit is expected to expand to allow the baby to come out, and yet the mom is laying on her back, on her sacrum, she's not getting that expansion. And research says that just by turning on her side, getting onto hands and knees, doing any other position besides laying flat on her back, that she gets a 30% increase. We got to get moms off their backs. It's education. They're with us pre-pregnancy. They're with us during pregnancy. So we can tell them, if nothing else, if you forget everything else I say, don't lay on your back when you're delivering. And it's not just that, they're laying on their back and their feet are in stirrups a lot of the times. Right. And so we think about anatomically, you have the aorta, you have the inferior vena cava, you have the baby and the uterus sitting on top of it. And so now you are essentially kinking off a hose. And so the hope is that, because if you kink off a hose and you're playing outside, sometimes water still does trickle through, right? And so you're gambling that enough blood and oxygen are going to trickle to the baby and enough toxins are going to get away from the baby. And the thing is that sometimes people say, well, the research is inconclusive on that. Then look at the person in front of you. When you said the research, listen, because I heard you say this and I was like, if everybody just thought the way that Dr. Seagraves thought, the research that needs to be done is on the person laying in front of you. If you have someone laying on their back and they're breathing just fine and the baby's heart tones are just fine and she's comfortable in that position, then by all means, if she wants to tear her vagina and pass that baby that way, that's up to her. If she's laying on her back and she gets short of breath and she starts saying, I can't breathe, and you look at the monitor and the heart tones are unreassuring, turn the mom. I do not care if she has an epidural and you don't have enough staff. You need to get staff to turn the mom.
Can we talk about the reality, though? The reality is she's going to C-section.
Yes, that's the reality. And so that's what I'm teaching these students. We are preparing them. I have teen moms who refuse to lay on their back. You can tell them what you want. They don't want to tear, so they're telling the doctor no. And that's what we have to teach you can say no, but we have to have the knowledge to know for them to say no. We had a mom, she was literally, her lips were turning blue. So she's Black, her fingertips show that she is not getting oxygen. And they were like, let's just go ahead and do surgery. You're not tolerating this well. And she told them, no, you will sit me up. The show stops now. It stops now. You will stop until you sit me up. Her husband pushed her up. And she was able to breathe and she was able to get the baby out. You want to rush to surgery for a position change? Like, that's why we need to be in L&D.
So you're teaching students things that will actually equip them to be in labor and delivery.
Yes, knowing that most places don't have it yet, but that Dr. Seagraves is on the move. So it's gonna be there.
Katherine, I revealed this. So this is my first live saying it, but I've been saying it in circles. Enhanced recovery after delivery is creating a standard of care, right?
Yes, ma'am.
Just like Operation Miss is creating a standard of care. That care happens regardless whether the hospitals give you permission or not. Yes. Let me tell you this for the record. We're training you to be there to fill in a gap in care that right now is wide open. No one is filling it. Our doulas are on the ground. Our midwives are on the front line. But when it comes to rehab, we are nowhere to be found during the first 6 weeks after birth, especially after C-section, or even in that time period right before delivery, to talk about the things that we were talking about today. Now, what you're saying is labor and delivery. And I will tell you right now, with this education, you don't need to have permission to work in a hospital to see this population. We just started this conversation out with concierge services. Dr. Sylvester, you started your business as an acute care therapist, seeing moms on their own dime. They were contacting you and you were doing home visits. You were already doing that work. So education is education. You use it, what you learn in PT school, but then you get more of it to actually build your career. And
Absolutely.
your career is not dictated by the place you work at.
No, no, it is not. And if it is, you will be that person that says, why did I become a PT? You will not make a difference, right? You talk about like what are we teaching? Why are we teaching it? If we know or mom knows that blood loss should be quantified. As a student, you understand if someone's urinating and they have a catheter in, right? They're counting the urine, they're checking the urine. I've emptied urine bags and put the number on because I know how important it is, right? And so we also have to teach they need to quantify blood loss. You cannot look at a person and say, oh, you look fine, right? That's what one of our moms was told. And I was so happy for data in that moment. I was so happy for data and the ability to draw labs because by the time they looked into it, her hemoglobin was 5.9 because they thought she looks fine. She looks fine. And so we have to not be afraid to advocate for investigation to be done, right?
I just, for the context for our audience,
Yeah.
because I feel like a lot of them are PT students, 5.9 hemoglobin.
Oh,
We learned in postpartum hemorrhage, first of all, actually, yes, we've been given newer guidelines that actually, even after vaginal delivery, they won't consider. And when I read this, I was like, I don't believe this. They won't consider it hemorrhage until it's 1,000 now. Right. It used to be, and you'll still read it. You'll still come across 500 for vaginal delivery, 1,000 for cesarean. They want to make everything one number. Of course, they go with the higher number, even though people will feel woozy after donating blood that's less than 500 milliliters. But
yes.
you're going to quantify someone who just gave birth at 1,000 before you feel like any intervention needs to take place. And then the hemoglobin, if you came in with a 12, you
And she
came in
was a
with a
13.
14.
Let's use real numbers. She was
Is
a
it real? Okay, 13 for
yeah,
a woman, pregnancy full term, has a baby, and she loses so much blood to where her hemoglobin goes down to 5.9. We still have some physicians, and someone told me this, Dr. Sylvester. I didn't even call you on the day, but it was a mid-level provider who couldn't make the call. Her attending refuses blood transfusions or iron infusions until they're symptomatic. So you're describing a woman who is probably asymptomatic. If she's our complexion or darker,
mm-hmm.
she's not showing pale skin.
No.
And also, she's a mother.
Oh
So
yeah.
she's being strong for her baby. So when they're not symptomatic, they're sent home with a hemoglobin that is below 7, that
Mm.
is below 6. And what is low hemoglobin for the students who are joining us? What does that do to your heart rate? What does that do to your infection risk? That's something that you need to look at. Because you're
Absolutely.
learning it in school, you're learning it in cardiopulmonary. Now you need to apply it to the different populations. In your school, I'm going to say this for the record, school is not responsible for it. They're teaching to the boards, let's just be real. Some of them are teaching to practice, some of them are teaching to patient care, but your school is meant to prepare you to become a licensed physical therapist. That's what your DPT program is doing. You are responsible for taking that information and turning it to the people that you want to serve. And I'm going to tell you right now with Dr. Sylvester, the biggest population that is not underserved is not being served. Let's call it what it is.
Yeah.
We're not talking about underserved people. There's nothing underserved about the maternal population. They're not served.
Right.
The biggest opportunity that you have to apply your PT education is to individuals that we're talking about. Whether you do it concierge, private pay, pro bono, whatever you want to do, or whether you change the system that you're working in as an acute care therapist, like Dr. Katherine Sylvester did for the neuro population, building an inpatient rehab unit in acute care. Who does that? Does that?
It needed to be done, right? And that's what it is with maternal health care. It needs to be done. So people will say, well, why do I need to learn that? I can't learn everything. And then that the fact of the matter is that you can't learn everything, but you can learn enough to protect the people that you're signing up to serve. And I think that is what has driven my education. Because even when you talk about the blood loss and the numbers and what's a good hemoglobin, what's not, I love telling students, depends on the person, right? So you can't just treat to what you see them doing, because in a hospital setting, again, it's artificial. So if you see her in the bed at 5.9 and she looks fine, you have to think she's been in that bed for 2 days because you all didn't get her up. Number one, help her get up. You put in a catheter. When she stood up and was symptomatic, you put her in the bed and gave her catheters and never said, oh, let's get PT in to see if we can work with her or get her a bedside commode, like you said, right? They didn't do that. Put in a catheter and thought that they would just remove the catheter and she would sign discharge papers. This is legitimately happening. But what we do, what we know we do, is we train for every circumstance. So if you ask a person, do you have, how many steps do you have? 20. So that person who went from a 13 to a 5.9 has 20 steps. And yet you're looking at her and saying she's asymptomatic while laying in the bed. And then you also have to think, so besides that, that's a problem, right? So we should
They
be,
do that all the time, though. Even our nursing staff on general floors don't assess blood pressure, Dr. Sylvester, with activity. So that's not just a maternal health thing. Like, people need to know, going into acute care, you're going to encounter providers, nurses, who are not assessing blood pressure with a person actually moving, or they're waiting 30 minutes for everything to calm down, and then they'll record the blood pressure and say that person is safe to go home.
right, right. And we can't do that. We have to be the ones to tell them. What we tell our moms is, when they come in to take your blood pressure, let them know, hey, I need you to wait for a moment, please. I'm going to sit up and you can retake it at that time. And then if you don't mind, once I stand up, then you can take it at that time. And then I'm going to take a shower, and I want you to take it after I take my shower as well. I really need to know and feel safe going, that I'm safe going home. And so you'll get some nurses who say, oh, that's orthostatics. We can't do that.
We need an order.
Think we need an order. And so that, to that person, then we say, okay, then we'll stay here until you get the order.
You will tell your moms.
Yes. Yes. Go ahead. Please repeat it. Absolutely.
You will tell your moms that you will not go home. You will delay discharge.
Yes.
Until they run labs, get a BNP, run your hemoglobin, check to see what that is, and take your vital signs with activity.
Yes.
And you're a physical therapist, just for the record.
I'm telling, we have to do this, right? We have to do this because we have to think about what we know, and what we know is not being done. So 20 steps. You're going to do me 20 steps too before I leave. Because I'm not going to be told, here's what I used to be told. Here's what I was told. That door is locked. That's what they said. That door is locked. Because, you know,
to the stairwell.
Stolen. Oh, yes, yes. Because, you know, they have all the code. I forget what it is now.
No. Oh, maternity unit is locked down in the hospital. I've been there.
They thought it was. When I got there, it wasn't. No, ma'am, they are not leaving until we get on a set of stairs. So I don't care what you have to badge me into or out of.
Because this is a mom who has steps to go up and down at home, and you're giving her an evaluation that is her home environment.
Yes.
You're assessing her ability to go up and down, which I will say, back to that vaginal delivery case where the mom was readmitted to the hospital for heart failure. She had steps, and she noticed she was getting short of breath after an uncomplicated vaginal delivery, where a physical therapist, occupational therapist, would have never evaluated her. So that's the standard of care that we're graduating our students into.
Yeah.
They don't have to keep it, though. Like, who told you that you have to work in a system that wasn't created to serve everyone?
Yeah.
Created to serve some, but it wasn't created to serve everyone. I had a podcast today with a urogynecologist that was asking me, well, I mean, what's wrong with the current system? She was asking it as a podcast person, you know, like a host should, being very like, just what's wrong with the current system of giving everyone a one visit follow-up appointment at 6 weeks postpartum. And I said, oh, that's a system built on equality. That's not a system built on equity. And then I gave her your example from CSM, where you had everyone in the audience stand up. I said this on her podcast. Everyone in the audience who was wearing heels, like I was, dying during this exercise that you had us do. I looked at you. I said, not today. And then you had people in the audience who were wearing tennis shoes, and you had us all run in place. And I said, that's the equivalent of giving everyone
Mm.
a follow-up appointment at 6 weeks postpartum, whether or not they're in heels, whether or not they're in tennis shoes, whether or not they are an amputee. You
Right.
are going to have people run in place regardless of the footwear that they have, instead of making it equitable to their specific circumstances and needs. And so that's the equivalent.
Mm.
That's your answer. That's what's wrong with the system, is that we're based on equality. We are not based on equity. Health equity doesn't exist. Health equity is not existing in your PT program. If you're teaching to the boards, you're not actually teaching your student who is telling you, I want to serve the maternal health population. I want a business that is not dictating to me who I treat and how I bill for my services. I want to create change in healthcare. How do I do that? If you are teaching to the boards, if you have shortwave diathermy in your curriculum still,
Stop.
you are not you are not teaching equitably to your students and to
Right.
their endeavors. Like, we have a generation that's ready to change. And
Absolutely.
we have teachers and educators who's ready to give them what they need. So if I'm speaking to PT programs, Dr. Sylvester, I'm going to pivot a little bit. I
Mhm.
do have to realize that our audience are going to be DPT students. They're going to want to know, how in the world did you get rid of PT debt in 5 years? You
Oh,
weren't paying one dime of PT's debt. And I was too. I mean, I think I'm looking at us as women of color, and I realize we're privileged in that way, that we didn't have the same kind of stresses in terms of that are dictating how our colleagues are practicing. Like, if I had 100 grand to pay off in PT school, I probably would not be doing what I'm doing now. I probably would not be advocating hard, and I probably would not be saying, so what, fire me. I have a certain mindset, an entrepreneurial mindset, that some DPT students are learning, but not all are, right?
yeah.
And so if you were to broadcast like a message that you wanted to get out to DPT students and you wanted to get out to PT programs, what would it be to help them really see the opportunity and the potential of creating a business and creating a service for the maternal health population today?
So I think first they have to recognize that there is money everywhere. Doesn't mean that you know how to. Some people will say, oh, I'll hire a grant writer. I have to have grant writing experience. That's not true. It is simply that you have to see a problem. You have to have a plan for solving the problem. And then you have to write to enough people before you get some revenue to put towards the problem. Because I understand that debt can make people make decisions that they would otherwise not make. But I also understand that when people start going down that line, then from a mental health standpoint, it's not going to be worth the trade off. And so so what I have tried to do is put myself in a situation where debt doesn't inform my decisions. So I don't have debt. I don't have credit cards. I have a credit card in case of an emergency, but I don't use it. And in terms of our viewpoint, I guess my view changed when I started doing home health hospice. So someone asked me to do them a favor. There was this new hospice place opening. They needed a PT. And I said, okay, well, I'll do it. I don't really want to be with that population because people think that they're dying. And I don't think that anybody can predict when someone dies. And so I think I would just be running into issues the entire time, which is exactly what happened. They told me you have 4 visits. So at visit number 4, I wrote so that I could get more visits. And then we get 4 more, and I just kept doing that. And then the person was functioning well, as opposed to just doing enough because you're tiding them over to when they die. We never talked about death, right? We talked about how are we going to make the quality of life as good as we possibly can. And people were living, understand, like for years after we were done, they are not dying because it's time for them to die. They're dying because you're not giving them the help they need to thrive. And so that's just what happens. And so with this population, I was like, wow, it's amazing. But what was more amazing was that they paid me $200 a visit $200 a visit. So if I saw 5 people in a day, I got a grand. At my hospital, I was making $65 an hour. So,
That's that's that. Some people would say that's pretty good. I was making 38 at the height of my career, but
okay,
$38 an hour. But go ahead, go ahead.
okay. So here I am working at every hour for $65. And I go to this company, they're paying me 200 a visit. And I was like, okay, when I do my cash-based business, I'm not taking less than 200 because I felt real good driving, doing the session, spending time with them. Like I felt really good about that. And people talk about reimbursement. Now, I did say that I don't want to depend on insurance, but Medicare reimbursed me better per hour than my job did. I got $166 a
Mhm.
visit, right? And so it's like they're paying me closer to that home health hospice agency than I was getting on my job. And so I was like, we cap ourselves income wise. We don't have to be in a place where we're in debt. We just have to make different decisions so that we're not in debt. And so I knew once I have a child, I'm going to have a lot of expenses. So I'm going to need to pay my student loans off before I have a child. So that was already my mindset. So every month, no matter what, I paid $1,000 in student loans. It did not matter what I had to say no to. I didn't go. You know how people are like, "Oh, now I have time to travel. I have time to do this." No, that was not me. I was not doing anything outside of eating rice, beans, maybe salad. Like we were every bill that could be cut down. That's what I did. So that was the first 5 years. It was super helpful because I had a husband, but we had expenses. It wasn't like he's paying for everything and all I'm doing is putting all my money towards student loans. No, we had other stuff to do, right? But $1,000 a month, no matter what, went to student loans. The other thing that I did though is I learned that if you are a PT and you're working in an underserved area, then you get your student loans repaid. And so every year I had to fill out this paperwork, and people were like, I don't want to do that. I'm not filling out that paperwork. I had to fill out this paperwork saying where I worked, like how long, all the things, and they would forgive 20% of your loans, like the rest of your loans. And so every year it added up to 20%. Yeah. So it's like 4% a year for 5 years. And
Yeah.
so that took care of a lot of my loans. So literally out of pocket, I paid 48 grand. The rest of it was taken care of by this opportunity that was given to me by the government. I was like, yeah. So it was easy because I looked for opportunities. I knew I didn't want to pay $75,000 back, right? And so I looked for people who could pay it for me. And so, I mean, because the money's out there. And that's what I'm learning with nonprofits too. When I am talking about people's needs being met. It's not always generous people like you who are like, oh, this lady needs a pelvic support belt, I'll send it to her. It's not always me going to Goodwill and buying a walker because I know the patient needs it.
Mhm.
It is that there are organizations that were erected to meet these needs, but they need people. And so they need the people to serve. We need our people to be served. It is the perfect relationship to enter into. So when I say when someone said, what has been the most effective use of your time? It's been building relationships. Every organization, nonprofit that serves moms, I have probably met with them at least once over the past 3 years because they have something that I need and I have something that they need. And so if you can, in the same way we started the conversation, the hospital needed to get patients out. I needed to feel good about the way patients were being treated. We came up with a solution that fitted both of our needs and we moved forward in that. Same thing with the maternal health crisis. You want to get into the maternal health space, then you have to find a problem and then meet the need, right? When you look at research about remote monitoring, what's interesting is that it's just really started coming out 2022, 2023. And almost all of the research is like, yes, this is a really good idea. Yes, we get a lot of good data, but it needs a person, right? We need a person to interpret this stuff. And I'm like, that's what's missing in all of healthcare, right? This is not revolutionary. You cannot use a machine to tell you what is going on with an individual because then you'll be that person who takes the blood pressure and doesn't even ask about the person's baseline. That's why I'm on the front.
So you mean AI is not going to be taking over our jobs?
Listen,
Listen, listen. I'm trying to break this down
right.
because with remote monitoring, I had
Mhm.
someone tell me it was the most ignorant statement I heard. And it was like, no, I don't want it to replace what I do. And I was just like, a machine will never replace you until it will. I mean, when a machine is able to actually ask questions about a person's environment, their support system, how many students, I mean, how many children they have at home. I'm thinking of talking to the hospitals and the schools and the therapists all at once. But if they can start asking questions that you don't have the time to, that is when you will be replaced. AI will definitely should replace you. Should
Absolutely. Amen.
replace you. But when you have a device and a person behind that device on a dashboard looking at your vital signs and seeing, okay, I know your doctor doesn't want to order you a blood transfusion, even though you lost significant amount of blood during your delivery, but I need you to ask about your hemoglobin, because I know that you can't draw labs from where you are, but you can see on their data by monitoring them via a smartwatch. Operation can see this is not right. You shouldn't leave.
Right.
And then empower that person to say, I'm not leaving until I know what my hemoglobin is.
Yes.
Come to find out is 5.9. I'm not leaving until you take my vital signs, because I don't have a shower chair at home. So
Right.
I'm going to have to be standing doing this. And I want to actually know where I'm standing physiologically. So you have built a company. And I want to end with this, because Dr. Sylvester, when students who are in 100,000 or more in debt think about the work it's going to take to create a company, you did it without any debt. Even I'm gonna use our time as a little personal coaching call. Even I can't fathom how you were able to write the same way you wrote as an acute care therapist for that Moveo. You were able to write $150,000 of grant money to fund your business, while the rest of us are like, oh my God.
You are so funny.
How did you do that? You have built Operation Miss to serve the maternal health population in a way that we're not seeing them being served in any, and I will tell you, in any setting. You're not going to get someone behind this database that's tracking your vital signs and telling you, hey, there's some things that I recommend you changing, like going to a hotel, getting rest, getting more water, changing your diet, changing your activity. Not everyone is meant to be running throughout their pregnancy. You may have to do more yoga. You're able to use that data and give them feedback, and then get a picture of what their home environment is like. And you created a business where you didn't have to put one dime of your own money into it. Can you leave us with something? Can you give us just a little taste of how we can get to this point of serving people the way they want to be served, but then also not exhausting ourselves?
So here's what I will say. Just like I say, the numbers for a person are important. So lab values, vital signs. The number for your business is important. So of all of the women who have gone through Operation Miss, there have been 73 deliveries. 0 have delivered prematurely. 0 have had miscarriages. 0 have had low birth weight. 3 have had C-sections. And they had C-sections because there was something in their data that said that they probably should. So they did not walk away feeling like something was done to me. They walked away empowered and requesting it because they were afraid that something was going to happen to either them or their baby based on what they saw. 3 out of 73. And so we have to keep the numbers. People will invest if they notice that, oh, she has a 4% C-section rate. And people in the United States, it's 33% or 30%, whatever it is.
33%.
In birthing centers, it's 9%. And yet she's able to keep these people from going this direction. Not, and what I'm telling you is that it's not always organizations that are going to invest it. It's people who hear this and then they're like, wow, I want to sponsor a mom. I've had so many people say, you know what? Here's a grand, go ahead and pay for that person's pregnancy. Organizations, of course, they do the same thing. We have low birth weight in these 2 counties. Can you please help us prevent these premature deliveries? Yes. And so now it's not even me writing grants all the time anymore. I still write them because I'm always like, you need a little nest egg, right? But it's not even me writing them anymore. It's people contacting me and writing us into their grants. And so it's like, keep doing the work, track the results, love the person who is sent to you. That is the formula. That is it. I promise you that if you do those three things, you will never have to worry. And then you have to watch how you spend, right? These last 3 years, I have never, and I've not made as much as I made in the hospital. I was making over 100 grand a year. I'm not making that with Operation Mist. And so you see, our lifestyle has changed as a result. I'm not going to live $120,000 lifestyle, and I'm not making $120,000 right now. And so if the cause is worth it to you, then you adjust until you're ready to go back to where you were before, if you ever return to that. And so for me, it's really just about track your results, because not only will organizations care, that's what's going to attract your clients. Moms want to be heard, seen, and feel safe. And they want to be loved. And so that's what we create. The data is a very small part of why people become a part of Operation Mist. The community, the love, the support, the empowerment. That is why they become a part. And so while we've caught things, there have been so many people who have avoided things because they've said at month 8, wow, my stress is up and it's not coming back down. They call their job and decide to work remotely. Hey, I still want to work. I still want to produce for you. Can I work from home? Let's just try it. And if it doesn't work, I'll come back in. It always works, right? And so it's how can we help these people thrive in the existing environment? It's not changing, right? And so we have to figure out, how do we be the change? Because I've heard that before, be the change you want to see in the world. That's all we're doing. And if you do that, the money will come.
If you can give a last piece of advice specifically to our DPT students, doctor of physical therapy students, they want to follow the trail that you have blazed. They just want to know how, when, where they can start. What would you say?
I would say, here's what I would actually say: see where your life and practice lead you. This path was not one that I chose. You know me, I was neuro all the way. I would have treated neuro till the day I died. And because I had so much respect in the hospital, I would have just worked there the rest of my life. This path chose me. My first son, my first birth, met with 4 women who had a cesarean delivery and a hernia behind it, in urinary incontinence, so she was peeing on herself, pain with intercourse, and then postpartum depression and difficulty losing weight. I was like, that's a problem. I'm going to meet that need. That was how I got introduced to women's health. Fast forward to my second delivery, and I have the postpartum preeclampsia, and I don't know what to do as a physical therapist to keep my blood pressure down. I'm doing everything I know to do, diet wise, moving, sleeping, like I'm doing it all. And it wasn't until Perry Brubaker sent me a watch and was like, "Can you wear this for us? Trying to see if we can detect COVID using wearables." I was like, "Sure." That's when I realized that a tenth of a mile I'm walking and my stress is through the roof. I'm eating cucumbers and tomatoes and boiled eggs, and that's seemingly healthy, but my blood pressure doesn't like it. And so we have to come up with something that's more individualized. Everybody deserves this. So I did it for free. I did 60 scars in 32 days when I came up with From Scars to Beauty Marks. I did that for free. The first 4 moms that came to me, I worked with them for free. The first 40 moms on the monitor, I monitored them for free. I decided this is the population based on my life circumstances that I believe I'm meant to serve, but let me try it out first. Let me write some grants, get some money, put the processes in place, make sure I can hire people to help me so that I don't go on the other end of things and try to do everything myself. Because the reality is that when you work for someone, all you have to do is give amazing customer service. When you are a CEO of your company, you market, you advertise, you provide the services for the most part for a pretty long time by yourself, unless you have a Dr. Jessica Thompson who just decides that regardless of her not getting any pay, until I could afford to have paid her, she was like, yes, I'm with you all the way. And so you're doing all the service, you're writing the grants if you go that route, you're doing payroll, you're doing everything. And so you have to decide, okay, I need to buy myself a little leeway. I don't want to go into debt. So I'm going to buy myself enough leeway. I'll continue to work my job. I'll stack my money. I stacked 60 grand before I left the hospital. 60. I was like, what do I need to last for the next couple of years in case I don't make a dime with Operation Miss? That's what I did. And so when I walked away, and when I tell you that the opportunities come when you're ready for them, I was only at 45 grand when I said that. I saved so much money because the $1,000 that I was using for loans, I didn't go on to then spend that money. I kept saving it, right? Why would I then go on to spend the money just because it was there? So I saved it, and then I put it into an interest bearing account. And so it's just gained money, not into the stock market, just into a regular account that gains interest. And so I did that. Someone contacted me about a pitch competition, ended up winning 15 grand. I needed 15 grand to get to the 60. It's because once you start putting your idea out there, you just start serving. After the 40 moms, I had the numbers I needed for the pitch competition. If I had went into pitch with an idea, but with no numbers, I wouldn't have walked away with 15 grand. And so it's just, you got to know what you really want to do. And then you have to have the discipline to just serve until you start seeing the results. But in the meantime, stack your money. You cannot say, I want to do this business and just expect that the money is going to come. That happens for some people. But for me, it took saving for a long time and then building, because to this Operation Miss is right to where it'll probably start turning me a profit next year. Okay. And so it's not like I'm in it for the money, right? I see clients for a week and I make $800 a week.
And you started Operation Miss when?
In April of 2021, and we monitored for free for the first, I don't know how long, but it has created a community, right?
You said 2021, Katherine.
2021, yeah. Yeah.
Katherine Sylvester, CEO and founder of Operation Miss. I am completely honored, utterly thrilled that you joined us today, and I am so thankful to call you a friend. Thank you so much for your time.
Thank you. I love you.